This
push them
conference will
along.
now
So
be
that's
recorded.
good.
Thank you. Hi, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, June 16, 2025. I'm Len Sierra, and I'll be moderating today with much help from my fellow moderators, Rick, Dr. John, and Ben, and all of you, our well-informed attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. All right, so we are going to start off with Mark Lichty.
Thank you, Len.
Mark, are you familiar with how we handle newbies?
You give me a chance to lay out my history a little bit and give me comments.
That's correct. So first, tell us.
So can I just say something? Because
Go
I
ahead.
do want to acknowledge Mark. We actually ask you the questions, Mark, so we'll take you through it. But
Right?
I've been working with Mark Lichty for a long time. I'm trying to think how long, but it definitely is before
Before COVID, anyway.
Well, it's long before COVID, and it's certainly before. I think it goes back to the very beginning of when we actually formed AnCan, or maybe even before. And what year were you named Man of Honored at PCRI? What year was that,
Oh,
Mark?
no, that was Howard that was honored for, I forget.
No, you were honored before that. You were honored 2 or 3 years before that.
Well, I'll accept your honor. Thank you, Rick.
And we met. I sort of met Mark at PCRI because he's a very long time Schultz patient, and that's really how we got our active surveillance group up and running. And then a few years ago, we went slightly different directions, and Mark had founded ASPI, which some of you might have heard of, Active Surveillance Prostates International, and they still run a very active program of webinars and goodness knows what. And we continue with the support group. So there you go.
Well,
Thank you, Rick. Okay, Mark, tell us. Mark, tell us how old you are.
Let me say something. Since Rick was kind enough to say those words about me, Rick, you care, and that's that. He doesn't have his hand out. He's not looking for money. He's not looking for pay, and it's the same spirit that we have at ASPI. Men show up, they're in need, they get help, and they walk away satisfied. And I was impressed with you, Rick. You spent 15 minutes on the phone with me today after I learned my cancer had spread. I'm sure you had better things to do, but you care, and I appreciate your caring. So thank you for that. So, Len, let me speak a little bit about me and why I'm here tonight. I learned about 3 months ago that my prostate cancer had spread to my lymph node. I had been on active surveillance for 20 years. Actually, as long as I knew anybody had been on active surveillance. And the odd thing about my case was that I had a micro ultrasound 5 years ago. I was given a bill of no evidence of disease 5 years ago. So I thought I was out of the woods. I thought I had a get out of jail free card. But then my PSA went up, not high, but 10.7 or something like that. But the urologist said, get an MRI. I got an MRI. It came up with either a PIRAD 4 or PIRAD 5, depending on who wanted to look at the PIRAD score. So they recommended a PSMA, which uncovered the cancer in my lymph node. So this reversed the readings of 5 years ago of the micro ultrasound. So obviously, I was shocked. I'm still in a little bit of a state of shock about that because I thought I had been cured. So now I'm at a point. What do I do? What was recommended was ADT and radiation. Now I've tentatively made a decision not to do ADT. Uh, why? Part of that decision is based on a very recent study, and the study indicated men who were given ADT. It was the group was divided into two groups. One was given ADT, and the other no ADT. And the survivability of the same with or without ADT was pretty much the same. So, and I'm 76, and I decided that I have a good immune system. I don't know whether any of you do your C-reactive protein, which is a measure of the health of your immune system, but mine's below one. You don't get it any lower than that. And I've been on a vegetarian diet for 20 years. I just don't get sick, period. And so I've decided that I have a good immune system, and that all went into my decision not to do ADT. Now these decisions can change, but that's my current decision as of tonight. But I think I'm going to go ahead with the radiation. And Rick, again, thank you for your thoughts on PEN. I'm going to follow through on that. But it's interesting. How do we judge the quality of our medical purveyors, our radiation people? For example, how do I judge the quality of my radiation person? I like that person. I don't know whether they're competent. And I'm sure if I asked them for references, they'd give me references and they'd be good references. But what's the point of calling them? So how do we really judge that? Well, I guess you call Rick Davis and he gives your name. I don't know. But so that's where I am.
Interject for just a moment, please.
Yeah.
C-reactive protein is a marker of non-specific inflammation. I'm a Gleason 9. I had metastatic bone cancer. My CRP has never been elevated, so that I would not trust that as a sign that your immune system is. I mean, your immune system may very well be in excellent shape, but that's certainly you can't go by the CRP.
Not that you wouldn't rely on. Thank you for that. We appreciate it.
Yeah.
Good.
Can I just ask, are you considering getting either the lymph node or your prostate biopsy to see what your Gleason grade is?
Well, it's interesting. It's interesting about the biopsy. So I haven't had a biopsy in 20 years. I had one, and it determined that I was a Gleason 6, but I never liked the idea of a fecal biopsy. It never made sense. I'm just a farm boy from Bucks County, but going through the rectum never made sense to me. Now we have the transperineal, and if I get one, it'll be a transperineal biopsy. But it's interesting because the radiologist just 2 days ago said, I don't know that we need to do that biopsy because he has the coordinates of where the cancer is already from the PSMA and whatever else. So he didn't feel that I needed a biopsy. I haven't decided that yet either, but I don't like to do unnecessary biopsies. If I don't have to do one, I'm not going to do it. But there was one other thing I wanted to bring up that I'd love some feedback on. Have any of you ever heard of a methionine-restricted diet? There is an amino acid called methionine, and it allegedly, if it's in too great quantity, it allegedly feeds cancer. Anybody here on a methionine-restricted diet or not? No, no one. Okay, that's interesting. Not, there's a doctor, Dr. Greger, who wrote How Not to Die, and he wrote he did a YouTube called he titled it "Say No to Meth" or "Say No to Methionine," advocating for a methionine restricted diet. So anyway, that's part of my regimen, or well, not quite. I'm going in the direction of trying to adopt that. I'm open to feedback. That's about my story about where I am right now at this moment.
Mark, what is your plan for radiation? Would you just do the lymph node, or would you do the prostate as well?
Yeah, they're going to do the prostate, and they're going to do very mild radiation of all the lymph nodes around. Like there's over a dozen lymph nodes around there, and he said the radiologist said not to. He would do that lymph node with the cancer, but he would do other lymph nodes too that didn't have the cancer because he's worried that there can be some undetectable cancer in those lymph nodes too. And well, I'm thinking, well, aren't lymph nodes related to your immune system? But he said, no, it's not going to affect your immune system. So right now I have to accept what he told me. Any other thoughts out there?
I see Jack's got his hand up. Dr. Jack, you want to?
Yeah. I wanted to get some information straight. I wasn't too clear. 20 years ago, you had a 3+3 diagnosis. You haven't had a biopsy or anything since then. You've had no treatment at all. And now at this point, 20 years later, it shows up that your PSMA scan shows a lymph node where?
Joining my prostate on the right side, I'd say.
I see. So it's right within the prostatic fossa, in the bed of the prostate. Nothing in the pelvic area, nowhere else.
No, nowhere else.
Okay, I just wanted to get it clear because it was a little vague to me.
Yeah.
All right. So regarding your question of how do you know which radiation oncologist to choose, Rick has got a long history of knowing who the best radiation oncologists are. So yeah, you would ask someone like Rick or anyone you know who's had radiation therapy and you who can speak up on behalf of that doctor. I don't know any other way to do it. Rick, you want to comment on that?
Yeah, I would. I mean, I would say, as for starters, that most of the time you want to pick a radiation oncologist from a center of excellence. And
Agreed.
for two reasons. The first reason is that probably they're going to have either the current equipment or only one generation out, but they're not going to have old equipment. Secondly, because there's not going to be a bias between proton and photon. Some of these centers, like for example, UPenn has both, so you can do proton or you can do photon at UPenn. So they're just going to tell you what they think is going to be best for you. And maybe thirdly, because you know that they're going to have plenty of experience. So that would be my starting point. And then from there, It's just really knowing, looking who's published, what they've published, and for us, of course, it's really important if we have patient experience. So that if we know doctors who have been who have treated AnCanners, and that's why we always ask you about your doctors. That's just huge. So that would be my answer.
Thank you.
Thanks, Rick. Let's see. We got a hand raised here. Oh, it's Ben. Go ahead, Ben.
So, without even knowing this guy's name, I have a hypothesis already, which is that if he didn't want to do a biopsy and he wanted to go ahead and radiate with radiation, to me, he's not very good at his job. I
That's
don't know what other
interesting.
people think. Maybe
Interesting.
everyone disagrees.
I don't disagree, Ben. I mean, there's lots of data out there right now around how to treat high risk disease. So at this point, Mark is basically a denovo metastatic. He's a denovo metastatic newbie. Yes, he's had 20 years of doing AS, but he was 3+3 back then, and maybe it wouldn't have been even considered cancer, which is where we're trying to take 3+3 to today. So I would see him as somebody who's de novo metastatic, and we know that high risk. If there's cancer in the gland, and I'm assuming that some cancer shows up in the gland, at least on the PSMA, the gold standard when it comes to radiation right now is SBRT to the gland, a couple of shots, or brachy, high dose brachy, plus the radiation across the pelvic girdle, which is what he's going to get, which is good, plus some amount of hormone therapy, anywhere between 18 and 24 or 30 months. And we know that that's the way that you can have the best chance of cure. Now, if people don't want to do the hormone therapy, and we've known people who don't want to do the hormone therapy, and they've had extensive disease, so they've been, Mark would be considered T4 at this point in time. Well, he may be considered T3A if it's very, very close to the prostate. So, I've seen guys who didn't do the hormone therapy, and 5 years later they were doing chemo. And but that's that's Mark's decision. If it were me, it was me. I mean, I was T3A at diagnosis, and I did 28 months. And today, if I was diagnosed that way, I would have done not just Lupron, I would have done abiraterone as well. That's what they get people who had my diagnosis to do. But everybody's different.
Ben, go ahead.
So, I mean, based on tumor burden, which are going to be large, kind of study that about ADT, no ADT, make a lot.
And you're going in and out a little bit.
Yeah, you're cutting in and out, Ben.
Oh. Okay, I'll
it.
say that. That better?
Yes.
That's better.
Oh.
Yeah.
I moved it like a millimeter. So I'll say it again. So this looks like a case where there's not a lot of tumor burden. So this would be a case like the study that Mark was talking about, where whether you get ADT or not, it doesn't make a lot of difference. On the other hand, I don't know if it were I, and the Gleason number were high, I would tilt in favor of ADT anyway.
So, Mark, when they did the PSMA PET scan, there was nothing lit up in the prostate itself?
Yeah, and in the lymph node too.
Oh, so it was in the, how many cores, or you didn't do cores, how many spots in the prostate were lighting up?
Well, there's two lesions. Yeah. And only one spot in the lymph node, that one lymph node.
Where are the lesions?
In
the
the prostate
prostate.
and close to the wall. That's
Well,
one thing that disturbed them, because the lesions were close
Yeah.
to the wall of the prostate.
are they on one side or?
You know, I should know that, but I don't.
You know, I'll come back to what Ben just said, because I think it is important. As much as you are reluctant to do a biopsy, in your particular case, it's going to give you a lot of information on how to treat. Because if we pull that out and it's a 5+4, God forbid, 4+5, or a
Yeah,
4,
yeah, I
4
got
plus 4, it's going to be a whole different ball game to if it's
you.
a 3+4.
Gotcha. Makes sense.
And it'll make you rethink. And Mark, I really get it. I know you don't want to go through. First of all, it would be a paranora. Well, it would be what you want it to be, but you know enough, and we know enough that we've advocated for transperineal enough that we would
Transperineal.
do transperineal. So you do a transperineal. We'll find out more what it is, and then you're going to make your decision. But I think it's an important piece of information.
It could be. I got you.
Somebody had their hand raised. David in Jacksonville.
Yeah, a question for the group. I'm new to the PSMA world, and is there such a thing as a second opinion? Is there such a thing as a false positive? Should he get a second PSMA or get a second opinion?
We always believe in second opinions. Can't possibly hurt.
Have the PSMAs always been accurate? Meaning, if it lights up, that's it.
No, the answer is no, but they're much better than they were. Originally, there was concerns if it was Pylarify because there were too many false positives with Pylarify. Pylarify's come more back into line, so the Illucix, and I don't know which one you got, but what I'm thinking is if you go to Dr. Vapawala in Penn, or you go to Karen Wang at Fox Chase, you're gonna have that second opinion built in when you go to see them.
Yeah. Gotcha.
Thank you.
Thank you, David.
Well, we have a busy night. Mark, anything else you'd like to hear from the group?
Perfect. And thank you all for your feedback.
Okay, well, thanks for coming and sharing your story.
So we didn't actually settle on a radiation oncologist, did we?
Rick gave me a name at
Okay.
who I'm
Okay, very good.
follow up with. I'm good on that now.
Thank you.
And thank you for that, Rick.
All right, we have another new member.
Can I say one very brief thing I want to. Would you advise letting a radiation oncologist manage this by himself, or would you also add a medical oncologist?
I talked to Mark earlier on, and I've given him 2 very good GU med-oncs.
Okay.
One at Fox Chase and one at UPenn. I would probably involve them as well, given the unusual history. I wouldn't hurt. We know both of them. I think we can get both of them to sit down with him. So Mark has a GU med-onc to back this up. Plus, he's been a patient of Schultz for 20 years, so he can cover that base.
Okay, Greg Van Hook, you are new. Are you still with us? Yes.
Yes, I'm here.
Okay, great. Very good. So I'm going to go through a series of questions for you, which we didn't do for Mark because we knew his history.
All right.
But we don't know yours, at least I don't. How old are you, Greg?
73.
Okay, and when, where do you live?
Upper Bucks County, about an hour north of Philadelphia.
Okay. And uh, let's see. When were you diagnosed, and what was your Gleason score, if you remember?
Um, 2017, my Gleason score was 9. It was a 4 plus 5.
2017?
Yes.
Okay.
Yes.
And what was your PSA at that time?
I think it was around 6. I saw the urologist because I'd been seeing my family doctor for physicals, and my PSA had been going up. So he suggested I go to the urologist, and then I had the biopsy.
You had a biopsy, okay. And what about scans? What type of scans did you have
Um,
at first?
you know, I actually don't remember. The only scans I really remember are the more later ones, the PSMA scans in 2022 and just a few weeks ago.
Okay, well, what happened between 2017 and 2022 when you had a PSMA?
Um, yeah, my prostate removed,
Okay.
and
What year was that?
that was 2017,
Okay.
or it may have been early 2018. This is a period that I don't have a whole lot of collection of for some reason. I'm not sure why, and I don't have the records because the urologist I was seeing, the office closed, and I never got a hold of the records myself. Um,
Okay, so you had surgery in early 2018,
yeah.
and any other treatment of any kind after the
Um,
surgery?
yeah. I was on hormones. And again, I don't know. Lupron and Eligard come to mind,
Okay.
but the first one I tried, I remember there were injections in my abdomen, and I
Yep.
had a I had a very bad reaction.
Right.
My skin turned bright red,
Pharmagon. Yeah, you
and
had Pharmagon.
oh, okay. And then they switched the hormone,
Right.
and then um, my PSA was still rising. So the urologist then sent me to um, a radiation oncologist, Dr. Brian Lally at Penn Radiation Oncology at Doylestown Hospital.
What was your PSA at that time?
Um, God, I don't remember.
Okay.
Um, and let's see. You know, I must have had some sort of a scan because Dr. Lally could not find a target for the reason my PSA was rising. So he said, I'm just going to irradiate your prostate bed. And so I went through, I think, 40 visits of radiation. And then about a year after that, I started having blood in my urine. And it turned out the um, radiation affected my bladder terribly. So then I did 8 weeks of um, oxygen therapy, hyperbaric oxygen therapy, and that pretty much took care of it. Stopped the bleeding, and then let's see.
Now, what year was that when you had the radiation?
That had to be in about 2020 because I didn't have radiation again until 2022.
After the radiation in 2020, do you recall any PSA measurements?
No, not from that time period. I
Okay,
don't.
so why did you do more radiation in 2022?
Let's see. I had the PSMA, and it showed a lesion on my femur, so that's why I had radiation there. It was
Okay,
I guess pretty minor compared to my first. It was only 5
yeah,
days.
right.
And at that point, Dr. Lally left Penn Oncology at Doylestown, and I didn't want to go back there because I really liked Dr. Lally. So I switched to, oh, in the meantime, Dr. Lally had me also seeing a medical oncologist. So I started seeing a doctor named Fern Anari at Fox Chase in Norristown, Pennsylvania. And my PSA was non-detect for months during well, maybe for about a year after that second radiation on my femur, and so I was feeling pretty good, and thought I beat it, and
Were
and
you
then
still on Lupron or Eligard at that
no, oh, I wanted to bring that up. No, Dr. Lally had me stop taking the hormones because my testosterone was basically nothing, and I guess he
Okay.
couldn't get a decent PSA number. I don't know. I'm just guessing now. Um, but yeah, I stopped hormones either before the first radiation or right around that time. Um, so I
Okay,
haven't
so
had hormones in a
you
long
had
time.
radiation in 2022 to the pelvic bone. PSA was undetectable for months after that, and then what happened?
Um, then then PSA. Well, I was just seeing Dr. Inari every 3 or 4 months at Fox Chase, and my PSA began to rise. Um, it got up to zero point 0.7 in March, and oh, in the meantime, I switched. I started going to Alliance Cancer back at Doylestown Hospital because I didn't like the commute to Norristown, um, and they had me do another PSMA because my PSA was rising again, and this time they found lesions on one of my vertebrae and um, in on my pelvis, and so then I went to see Penn Radiation Oncology again at Doylestown Hospital, um, and they didn't want to irradiate the lesion on my vertebrae because they said it was too close to my spinal cord, and so they were going to send me to Perlman Penn in Philadelphia. Um, so then I went back to Dr. Anari at Fox Chase, and she referred me to an oncologist at Fox Chase in Buckingham, basically Bucks County again. Um, I think they have better equipment, but I mean, I don't know. I don't know. They have a cyber knife. That's all I know, and some other stuff. So I have an appointment with her in about a week. Her
And what's her
name's
name?
Shelley Hayes.
Shelley Hayes.
So when I left Penn Oncology, radiation oncology at Doylestown, my next step was to have MRIs of the two areas, of the two lesion areas that were just identified. So that's where I am. I'm going to talk to Dr. Hayes.
Has Dr. Inari put you back on hormone therapy?
No, she kind of left it up to me, and at the time I was like, I don't want to go back on hormones, but now I'm really second guessing that. I'm wondering maybe if I
Yeah,
should.
I mean, this is. I know that you've sort of cycled between 2 or 3 different places. Dr. Inari is a GU medical oncologist. I don't. I have to look at her training, but she is. Let's see, educational background. Where did she change? She did a fellowship at Fox Chase. So she was at Thomas Jefferson and she did a fellowship at Fox Chase. So she has pretty good training because they know what they're doing at Fox Chase. But the way she's handling your case just sounds weird. If it were me, I would do one of 2 things, and you may not be able to switch within Fox Chase because it's very difficult.
Oh, is it?
But
Okay.
it's difficult to switch doctors, yes. So and it's difficult at Fox Chase. We know because we've known people who try it. Sometimes you can do it, sometimes you can't do it. So, first of all, I wouldn't go to this Shelley Hayes. I would go, even if you have to drive, I would go to Karen Wang, who we know is good at Fox Chase.
Okay.
Because you really want to go to somebody who knows what they're doing, and we know she knows. And there are some other good people, not just Wang, but we know people that Wang has treated, and she's good. Or, much like I suggested to Mark Lichty, kind of start over and go see Vivek Narayan as a medical oncologist, and Dr. Vapiwala for a radiation oncologist at UPenn.
Oh, okay.
And because it just, this has been going on a long time, and it's never been nailed. And how many lesions showed up in your PSMA in 2024 or 2025, whenever they did it just recently?
2.
2?
2, yes.
Okay, so yeah, I think I would. I mean, you got to get some solid quarterbacking, and it's sort of going between the Radonk and Dr. Inari, and now there's another one, and that would be my. I mean, what does anybody else say here? Len? What do you think?
Yeah, absolutely, Rick. I think, Greg, you need to choose a good GU medical oncologist and stick with that person. Try and deal with any idiosyncrasies that you feel might otherwise turn you away from them, because it gets very confusing if you're going from one doctor to another. You don't know where your records are. You don't seem to recall your PSA values. What about genetic testing? I don't suppose you had any genetic testing.
Not for this, no. No.
Yeah. And Inari is dropping the ball there, because in a situation like yours, it's called for in the NCCN guidelines. And you should have at least had germline, and she should have been thinking about how to get some somatic evidence. So, I can tell you, if you'd been seeing Dr. Gainesman at the main fox chase, he would have done all of that. So I don't know. I'm not too sure. I'm not too sure.
Okay. Well, I've got a telehealth
Greg,
appointment.
let me just say this, Greg.
I'll ask her.
You have what we call systemic disease. It requires systemic treatment. That means hormonal therapy, as your base. And then you can add on something from that. But you should definitely be on systemic therapy.
Yeah.
Okay.
Yeah, I mean, it's a surprise to us in this room that Inari didn't say right away, oh my gosh, you've got to go back on Orgovyx and abiraterone. I mean, that would be the first move. And then we can also talk about radiating these spots.
Wow.
So, I don't get it. Peter H., you have your hand up.
Sir, I just want to say, Greg, I think that you're not good at advocating for yourself.
You're right.
You're allowing these doctors to kind of push you around. Is there someone in your life who can help you? Quarterback.
If my wife went to these appointments with me, I would probably be in much better shape. Yes.
Okay. And why has that not happened?
Well, she has her own psychology practice. It's really difficult for her to take time off. That's mainly it.
Okay. Does AnCan have any, advocacy, volunteer type role?
Yeah, that's a good question, Peter. We have in the past, people that might go along with you, but I think you have to lean on you start advocating for yourself by leaning on your wife. Yeah. This is your life we're talking about. And normally where we have people come in, it's because they don't have anybody else.
Oh.
And if they don't have anybody else, we're happy to help. But you have a wife who's a medical practitioner, and you need somebody with you. Are you recording? Do you record your conversations when you go in? Oh. So no. we can't re-listen to them. She can't re-listen to them. You're just getting messed around, man. I mean, you have to. Peter's observation is a terrific. Peter Huck's observation is a terrific observation. He's right. He's spot on.
Mm-hmm.
You can't. You have to be able to. Educate yourself and articulate what you want and what you don't want. I'm sensing that you just kind of wishy-washy and you should. I don't know about recording your conversations. I don't know if any doctor wants you recording, but
no, it's common. It's common, Peter.
Is it? Yeah.
It's common, and what we tell our people is if the doctor says you can't record it, you need to get up and go find a doctor who says you can record it.
Okay.
Right. Most doctors today will do it. The doctors who don't, we're suspicious of.
Okay.
Peter, I wouldn't necessarily say that Greg is wishy-washy. He's just not informed. He probably doesn't even know which are the pertinent questions to ask. That's why he needs an advocate. And his wife sounds like she might be better at that than he is.
Yeah, I've thought about that a lot today. Because at the end of all these appointments, the doctor will say, "Do you have any questions?" I don't know what I don't know is the problem.
Right. Okay.
No, I don't ask the right questions.
Well, this group, Greg, is a plethora of information, and you just come and you just sit and you listen, and you don't necessarily need to be the center of attention, but you need to listen. Take notes. I used to take notes all the time. A lot of these guys throw around terms and medications that I don't know how to I don't know how to pronounce or I don't know how to spell. So I'll look them up on my phone while they're talking and just try to kind of educate yourself about what your options are.
I watched earlier today. I watched the previous group forum recording, and I was just amazed at the information that was
Yes.
coming out. It was,
Yes.
I mean, yeah, you're right. Yeah.
Greg, what does your wife do?
She's a psychologist and a psychoanalyst.
Okay, she can probably be a perfect advocate for you. Yeah, tell her
Yeah,
that, listen, honey, this is really important. My life is on the line here. I'd really appreciate if you could, take some time. It's not that often that you see the doctor, or maybe you could even do a video visit, which would be more
yeah.
convenient.
Well, we have a son. I don't know how. We have a son who has certain conditions, and she became his advocate, and that's actually what led her to the career she's in. I mean,
Right.
asks all the right questions, and I really do wish.
So, Greg, this is John. Just to summarize, so Glenn can move on. The right questions to ask right now are get to Karen Wang at Fox Chase or back to UPenn for a radiation oncologist and get focal treatment for your metastases in your vertebra if it can be done and in your pelvis. Get to maybe Dr. Narayan for medical oncology and probably back on hormone therapy. Get
Okay.
genetic testing.
Right. Dr. John,
Even ask Dr. Narayan whether you should be on a bone strengthener because this is 3 bony metastases now.
Yeah.
And Dr. John, I would say that if you're going to go to see Dr. Narayan, you should tie that in with seeing Dr. Vapiwala. Vapeiwala, Dr. Vapiwala. She's the radiation oncologist at UPenn that we really like. Oh my gosh, she's we've had so many people go to her and they all love her.
Really?
And I've met her and she's really, really great.
Gary in San Francisco, you've had your hand raised for a while. Go ahead.
Yeah, I just want to say that when I was first diagnosed, my wife decided to stay out of it and let me make up my own mind, so to speak. And that was a mistake. And when it came back, I did the exact opposite. And I am enormously grateful for her help and support, and including her, her looking up things online and becoming, more than just holding my hand or patting on my back, but she's another mind. The other thing I would say is you really need to start keeping your own records. If there's any way you can go back and re-establish your past records, that might be a good idea. But from here on out, get a copy of everything, set up some sort of filing system, a 3-ring binder, whatever, so that it's not just a pile of paper, and read through and become familiar with what's going on. And because I think that's a very important thing.
What a good suggestion, Gary.
Yeah.
All right.
Yeah,
Thank you.
and Henry has a good suggestion too. He's saying if your wife can't be with you, put your phone on speaker. Maybe your wife can listen in during your visit with the doctor.
Yeah.
So
Okay.
several ways you could do this.
Yes.
Okay, so Greg, we're going to have to move on. We've got
All right.
another
Thank
new
you.
person.
Thank you all.
Yeah, thank you. I'd like to get to Pete Gates. Raise your hand, Pete. I don't see you.
Well, can you hear me?
I can hear you, yes. Oh, you don't have
Okay.
your camera?
Well, let me see what I can do right here, because that would be
Definitely be helpful to us if we could see you.
exactly.
But if you can't do it, we can work without.
Well, how about this? Does that help at all? No, no, yes,
No,
I don't know. Does
no.
anybody see Pete?
no,
Oh, how
All
about
right.
that? Yeah,
nope.
Nope.
no. Turn
Are
camera
you
on.
using
Camera
your
is on.
phone?
Could turn off the camera's on, like that. No.
No.
Oh, I see. It's buffering. It will probably do it forever.
Oh, okay. All right. Let's
Let
try
me
and do this without
let
the
me try
camera.
one. Let me try one other thing here. I've got a list of participants. I'm trying to find settings that I had earlier.
Camera switch is on the bottom of the screen.
Right, and when I hit that, it continues to buffer,
Gotcha.
and I'm not sure what's causing that.
You must not
Hey,
somehow
Len,
have the
Len,
bandwidth.
we don't have a lot of time now, and we've
Exactly,
got a
but
bunch of
we
people,
can
so let's just proceed without the picture.
Yeah. Yeah.
absolutely.
Okay.
Sounds good.
All right, Pete. Tell us how old you are and where you
I'm
live.
70. I'm 75 years old. I live just outside of Anchorage in Alaska.
Okay. And how did you hear about AnCan?
I've got a very good, beloved brother-in-law who lives in D.C., and he strongly has recommended you folks and your activities and all of your good work that you're doing. And I've been putting it off, and one time I tried. I'm just not technically adored with those kind of skills.
Is he a member of AnCan?
Yes, Richard Fisk is with us tonight, I think. Richard?
Oh, Richard Fisk. Yeah, of course. All right. All
We
right.
know him.
So, Pete, what is your Gleason score? What was your Gleason score on diagnosis? What year was it, and what was your PSA?
Well, the diagnosis happened in September of 24. My PSA at that time was close to 30.
Okay.
I then went to an oncologist. And by the way, everything we're talking about is VA oriented.
Okay.
My entire experience for 20 years, when I thought I've had 3 biopsies in 20 years, and the first 2 were considered benign. There was absolutely nothing detected. So in September of 24, I was able to get in and see a urologist at J-Bear, which is a military installation outside of Alaska, and at that time we decided it was going to be another biopsy. She took 12 cores, and it came back with a Gleason 5 + 5 equals 10. Prostate adenocarcinoma, stage 4B. I'm not sure what the B means. Metastatic, very high risk, grade group, Gleason 5 + 5 equals 10. Big group
B
5.
means that your metastatic lesion is outside the regional lymph nodes.
Correct. Outside, well, you say outside of the lymph nodes. It was explained to me, and we had a PET scan that carcinoma was found in lower abdomen and pelvic area, had hit and had metastasized in a lymph nodes, but had not hit bone. And so I had that, and I December began a chemo treatment, and I'm going to read some stuff from that consult that I had with Dr. Liu at Alaskan Oncology. He recommended triplet therapy with ADT plus androgen receptor blocker plus docetaxel. And we began that at the end of December. My PSA went from approximately 30 down to 2 within a month of two chemo sessions. It now sits at 0.04. My chemo, I'm finished with my chemo just as of a month and a half ago. I've already had a consult with a radiation guy, and in fact tomorrow I have the procedure that rectally implants gold seeds in order for the radiologist to mark her in on, as I understand it, and that's kind of where I'm at now. And just as an aside, there is nobody in my life that can handle this except for me. It's just, that's the way it is. I'm a musician. I'm hardly ever home. I travel all over the state, and I fit doctor visits and medical stuff in between. So,
Well, congratulations! Your triplet therapy was very successful.
In terms of PSA, yes.
But not in terms of what? The way you feel?
Well, the Gleason score has me really going squirrely. I thought I was doing fine. I did have a sit down in my consult with a radiation doctor. His name was John Yorty, and he made some recommendations. And after these gold seeds are in place, as I understand it, I'll begin a radiation program of 5. I guess it's 20 visits. It's 5 days a week for 4 weeks. And that'll begin, I guess, after this appointment I have tomorrow for the implanting of those seeds.
Yeah, so they're treating very aggressively because you have very aggressive cancer. It's a very aggressive Gleason score. You can't get higher than that. So,
and I'm in pretty good shape otherwise.
Great.
So,
great.
Yeah.
Now, what about any genetic testing for you, germline or somatic testing?
No, and if you genetic testing involves relatives in the past, etc. There's been no cancer in my family.
Okay, well that's germline. Then there's another type of genetic testing they do where they look to see if there are any gene mutations in your tumor cells.
Gotcha. No, that has not been done.
That should be done, just to rule out the possibility that you may have some mutation within your tumor cells and be treated, be targeted with some drugs, because we do have such drugs.
And then would a generic test be administered by, or be put on by an oncologist or a urologist?
The oncologist would order it. He could use biopsied material if it was fairly recent.
Right. Well, September.
Yeah, September. That's recent enough, I would say. Yeah, I would start with that.
Okay. Well, and
it could be done, from your blood, but it's probably better to work with the pathology tissue.
Okay. So it would be the oncologist been with for the last 6 months that I would discuss, not with the radiation doctor. Correct?
Yeah, the one who gets you on the triplet therapy, that would be the one to.
Yep, that would be Dr. Lou, in Anchorage at Alaska Oncology. Okay.
Yeah,
I've got a note on that.
Dr. Lou should have ordered that as a matter of course.
So I've had paperwork, and
let me just go on here a second. If you were being treated in a VA hospital rather than in community care by the VA would have done that. The VA would have given you a germline test, and then they would have subsequently given you a somatic test through your blood, maybe before you started the chemo, or subsequently they would have given you from the biopsy. But yes, you definitely need to get it done. Jim Marshall will definitely come to you. Don't worry. What ADT? What ADT ADT drug are you on, and what ARSI drug are you on?
Well, if you refer, yeah, in the plan was beginning in December was to start ADT leprolide. Am I pronouncing it right? Leuprolide, 7.5 milligrams for the first dose and then transition. And then I've been taking darolutamide on a daily basis, 1,200.
Okay.
Yeah,
Dr.
1,200 a day.
Did Dr. Liu give you bicalutamide before he started the Lupron? Did he give you a drug before he started the Lupron?
I believe so.
Was that
and if you say
bicalutamide?
starting the Lupron, you mean the chemo, correct?
No. The Leuprolide is the ADT drug. It was an injection, right?
I believe so, yes.
And before he gave you that injection, did he put you on another drug for 10 or 15 days before that first injection?
I couldn't tell you. I can't remember. That's not coming to mind.
Okay, well, it's not that long ago, so think back. And I'm asking for a very good.
It would have been a pill, an oral pill. So you probably remember taking some kind of pill.
An oral pill. And
I have taken thousands of pills.
Okay,
Pete, it wouldn't be the doxycycline.
No.
Okay,
Pete, this is within the last few months. I mean, they put you on Leuprolide, they gave you an injection. The reason I'm asking is if the doctor did not give you that pill before he gave you the Lupron shot, you need to get out of his practice. Because that.
So then I'm going to assume that he did. With that statement of yours, I couldn't see how he wouldn't. You sounded so definite on that.
Well, because there are some people who practice with genitourinary medical oncology, and they don't know what they're doing. So he looks up and he sees how many lesions you have, and he says, "Oh, this is a good candidate for triplet," and then he follows the book. But the fact is that because he gave you Lupron and he didn't give you Orgovyx and he didn't give you Firmagon, which he should have done.
No, I'm not seeing any of that.
Right. So you should have done something first. Now, what we're saying is this is a sign of a doc who doesn't know his way around prostate cancer. If you are at the VA, you can get Orgovyx. It's a much better drug. It's a pill you take, and you shouldn't even be on the Lupron, and we shouldn't be talking about this. But we're trying to help you in terms of navigate. But you
every
need to
3 months.
out.
Every 3 months, I was, every other month, I was injected with, in the stomach, and that may be what you're referring to.
Okay. So the first, you said Leuprolide, but if you got injected in the stomach, that would have either have been Firmagon or Eligard. Now, if you got Firmagon, you didn't need the bicalutamide, but Firmagon is not called Leuprolide. If you got Eligard, then you still might have gotten, they give Eligard, I think, or Zoladex, one of those two in the stomach, but then you would have needed the bicalutamide. So
start APD.
I'll go back to what, I think, who was it? It was Gary said. Got to keep really good records and know exactly what you're getting. You can only you can advocate for yourself. And if the doctor isn't treating you right, we can help you. We can point it out. We can give you the questions to ask your doctor, but we want to make sure. The second thing I want to say to you is this, because I've actually been hearing this recently. I've been listening to some very good doctors on ViewMedi recently, and there's a number of studies, the AnCan study and some other studies, that says that if you get down to less than, or if you get down to undetectable, which is where you are at 0.04, your outlook is exceptionally good. If you if you would have been above 0.2, that at this point it would have been a problem, but you're doing great. Okay.
the horror stories that I read about radiation, it concerned me. And when I did further looking at what a Gleason score really was, well, that even continued my increase in concern. All of my
Radiation
good
is not
feelings thus far
horrible.
had been dealt to the PSA.
Right. Don't go in, if you don't know what you're looking at, don't dive into Dr. Google. It'll make you nuts. Bring it
I'm
here.
trying not to.
Okay, bring it here and we can explain to you. Dr. John just chimed in on radiation. He can talk to you. We can present it to you in a much better way because you don't have the filter to interpret what you're reading. 5 + 5 is bad. Is bad. But spend your time keeping your records, knowing exactly where you went. That's what's real important. Let's just go because I'm keeping an eye on the time. I know we've got to finish up, but let's go
three
to
hands up too. Let's go to Jim. He wants to talk to you about the veteran support group. Go ahead, Jim.
Okay, first of all, Lupron Eligard comes with a 1 month, a 3, 4, and a 6 month shot. Okay, that's just so. Okay, on the veteran support group, are you currently a disabled veteran?
No.
Okay, there will be a veteran support group run tomorrow night. I put my contact information. I will put my contact information, okay, into the chat. Do you know how to get to the chat log?
Sure. Yes.
Okay.
The chat log regarding tonight's meeting.
Yes, the chat
Yeah,
log.
I'll be
I
able
will
to
put it in there, and
Okay.
I will send you the reminder notice. Okay, after we end here, and you can attend it tomorrow night, essentially 8 o'clock Eastern time, which I'm not quite
we
sure.
need an email address, Jim.
Yes, I will put my email address into the chat, and then he can send his email address to me, and I will send to him the reminder because it's already gone out.
Okay, very good.
And I'll be
That's
happy to do
appreciated.
that.
All right,
Thank
Lee,
you.
you're up. Lee, you have a question.
I do. I just have a quick comment. I've been fighting this war for 10 years and learned a lot along the way. But I've listened to 3 guys tonight who are treating this as though it's a bad cold. And they go to a doc and, oh, I don't like that doc. I go to another doc.
Perhaps some of us are
Guys,
just
we
putting
are in
too
a
much
fight for our lives.
info in
And you've
the
got to
medical
have
doctor.
information. You've got to know what's going on. You got to aggressively collect records, keep them. If you don't understand them, you've got to come to a place like this and get the kind of information you need. This is not a casual fight. You can't, this is a gunfight, and you can't come with a pocket knife. You got to come bearing information and knowledge and
Okay,
come to
Lee,
the
I
right
think he's
place to
got the
get it.
message. Lee, we've got to move on. I think I accidentally put someone's hand down. Did someone have their hand up and get it shut down?
Doug.
Doug, yes. Go ahead, Doug.
We can't hear you, Doug. You need to select the right microphone. The wrong microphone is not selected.
Yeah, we can't hear you, Doug. We'll see if we can get back to you later. Meanwhile, we have to. Oh, Pete, are there any final questions you have for the group?
No, there are none. Not that I can remember or aware of.
Okay.
Okay. And Pete, please could you send me, or if you're comfortable putting it in the chat, put it in the chat, or send it directly to Rick, your email address, so we can get you properly registered for all these meetings.
Right.
Absolutely, will do.
Doug, go ahead. Let's see if we can hear you. Nope, still can't hear you, Doug. Sorry. Maybe put it in the chat. Let's see. Bill U. It was untied. Yeah, go ahead, Bill.
Just wanted to give a quick update on my treatment. I'm a Gleason 8. My PSA was 7.9 before treatment. I did 28 sessions of proton therapy with Dr. Rossi in San Diego, starting in late December, and everything went great through that. I was amazed too. Before I went to radiation, I've been on Orgovix. I had been on Orgovix for 11 weeks prior, so I had a PSA test out of curiosity before the radiation, and it brought it down from 7.9 to 0.42, which I thought was great. Went and had the radiation. Everything went great, and last week I had my first PSA test post radiation, and the result is less than 0.04. So that's
Terrific.
where things are. I'm continuing on Orgovix. Recommended 18 months. I've got about 9.5 months to go on that, although I'm thinking about I'll address it at that time, but to see if there's any value in going longer with ADT, because it really hasn't been that bad for me, the ADT. Yeah, I have brain fog, I have fatigue, but I can definitely live with it. And and my ED went away after about a month, which was fabulous. I've been on low dose Cialis since about 2 weeks after I started Orgovix, because the Orgovix right away, no libido, no erections, but now things are back. The libido is still pretty much non-existent, but everything else seems to be coming along. So,
Okay, count yourself as one of the lucky ones. That Cialis doesn't usually work when you're on ADT.
interesting. Thank you.
It's a good report overall, Bill. You responded
Excellent
nicely to
report.
treatment. Did you, by the way, end up with Dr. Antanarakis or no?
No, but he is, so I went to Dr. Rossi, as my RO,
Mm-hmm.
and I've looked up Dr. Antanarakis is in my network, and I checked. He is taking new patients, and though at this point I'm not sure I really need drug guidance, I thought I would make an appointment anyway to see if I can kind of get on his books, so that when that time comes, then I'll be,
Yeah.
Well, the
He
time
got-
will come in about 6 months. You'll be on 18 months on ADT and starting to plan for when to
Yeah.
get off of it. That'd be a great time for a talk with a medical oncologist.
Okay, thank you.
But make hay whilst the sun shines. If he's taking new patients, grab him, because he may not be taking new patients then. So I would say yes, can't hurt, and he knows who we are, and you've got him on your team.
And I watched a great talk he did for the Mayo Clinic support group. Oh, I don't know when that was, 4 months ago or so, on his bipolar ADT research, and
Mm-hmm.
I was just so impressed with him. And yeah, I'd just like to see if I can get on board so that he'll see me in the future.
Great report.
I'm
All
very,
right, Bill,
very
thank you.
thank you.
Now we'll go to Stephen T.
Hello, thank you. After listening to the discussion this evening, a couple more things came up, but there are three things I'd like to touch on. I suspect there won't be time to do all three, but one is I've got results from genetic testing that I'd like some help interpreting. Another is I'm interested in connecting with anyone who has an enlarged prostate that predates their prostate cancer diagnosis. And the third thing is I went to University of Chicago last week to see 3 different oncologists, and the pathologists there gave me a Gleason score of 4 plus 3 equals 7, whereas 2 previous pathologists from different medical systems gave me a score of 4 plus 5 equals 9.
Oh boy.
What,
Including
what,
cribiform and IDC.
which topic do you think is the most
Well,
useful for me to discuss? And
okay,
I'll pick up
let's
the other
take
2 another time.
Let's take the low-hanging fruit. Did one of your readings come from either Dr. Epstein or Dr. Zhao?
Dr. Zhao, yes. Ming Zhao.
I would rely on whatever Dr. Zhao said.
Okay, he's a 4 plus 5 equals 9.
Then I would say that's what you are.
All right, thank you.
What was the next one?
Gene testing.
Okay.
Yeah. A lot of information there. Summary says variant of unknown significance detected, and interpretation says no known clinically actionable alterations were detected. Is that kind of a clean bill of health there as far as genetics goes?
Wouldn't call it a clean bill of health. I would just say there are no drugs available to target whatever mutations you might have.
Okay.
And we don't know if that was a cheek swab or a blood test or a biopsy sample.
It was a biopsy sample.
Okay.
So I think that was a somatic.
Yeah, good.
Suspecting that was a somatic. What was the gene mutation that had a VUS, a variant of unknown significance?
Yes, it's the N as in Nancy, T as in Tom, HL number 1.
Don't know, but
I've just been reading about that one, Rick. Oh, let me find it.
Okay, go ahead.
I can't find it. I'll try to find it. He has a sister with breast cancer.
Yes.
NTX 3-1, is that what you said?
No.
Sorry, no, it's NTHL1.
Oh, I'm sorry. Okay, forget I said anything.
False alarm, okay, thank you.
Okay, Ben, what do we know about NTHL1? Professor, come on in. You're muted. You're muted.
No longer. If it says uncertain significance, that's all she wrote.
Yeah. So the reason I ask is because, just like Ben says, when it says uncertain significance, there's not much we can do about it. But sometimes with some of these VUSs, things happen and they will let you know. And I was just curious what it was. But I would say that, yes, by and large, you're in pretty good shape there, and we're good to hear. What was the third thing? Let's get to it quickly, and then we'll move on.
Thank you. I'm interested in connecting with anyone who has an enlarged prostate that predates
Okay, well, we
their
have at
prostate
least
cancer.
one person in this group who has an enlarged prostate. I know for sure, because he's been very public about it, and he's given a lot of BPH advice, and that's Mark Lichty. So send a note to Mark and exchange your emails with Mark. He's one person, but his experience in treatment is kind of he's right at that same point that you're at with an enlarged prostate. Is there anybody else who had to seek treatment with a large prostate tonight?
Well,
Steve L.
Yes, I had an enlarged prostate for at least 8-10 years prior to finding my cancer, and my cancer treatment has actually reduced my prostate in size to much smaller than normal, and most of the um, problems with a large prostate have gone away as part of my cancer treatment.
May I ask which treatment you selected, or have you had them all?
Well, had them all. Starting with starting with with um, androgen deprivation therapy and abiraterone, and then that actually just those two together did quite a bit. I've then had Provenge, which may or may not have affected the size of my prostate, and now radiation, which has, I think, made my prostate even smaller.
So, Steve, the hormonal therapies are very reliable as a drug to shrink your prostate.
Okay.
Have you taken any hormonal therapies yet?
We're still
No,
holding our breath, Len, for Steve to start treatment.
yes,
Okay.
yes. And I have been told that by rad oncs that the shrinkage that's due to ADT is temporary, that once I go off the ADT, there's no guarantee that the prostate will remain shrunk.
But you're going to be 2 years on treatment. That's far away.
Okay.
Yeah, but they'll usually give you hormonal therapy to shrink your prostate before they do radiation, and possibly even before, no, probably not surgery, but certainly before radiation. And as a matter of fact, I think they don't like to operate on a huge prostate, guys. Isn't that correct? They would prefer to shrink it first with hormonal therapy and then use radiation.
Yeah.
Well, none of the surgeons I've spoken with so far, and that's been 3, have said anything about ADT prior to the prostatectomy.
Russ, what's on your mind?
Well, I was going to say, it's important to understand why the ADT shrinks your prostate. It lowers your testosterone. Your testosterone converts to DHT. DHT is what increases your prostate size. As long as you're on ADT, that's going to shrink your prostate. You go off ADT, yes, it can rebound, it can grow again. You can go on finasteride or dutasteride. Those will shrink your prostate too.
Okay. So,
Thank you.
I know you're working with Dr. John, so you've just got to keep getting more information. And I mean, this prostate size has been an issue for you since we first talked to you at the beginning of May. So I think you're just gonna have to figure it in, Steve. We can't really help you more on that. I don't know that you need to talk to more people. I mean, I think that how big is that prostate? Was it 70 something from memory?
I think it's 72.
Yeah, so 72 is not huge.
Yeah,
And it's big, but you probably can do either one with 72, I would think. That's sort of right around the limit, I think, on the surgery, but I'm not certain. Don't quote me.
Okay.
So that's why they haven't talked to you about ADT. If you had 100 cc prostate, that would be a different ball game.
Okay, thank you all very much. Thank you.
All right. Thank you, Steve. David Muslin, are you still with us? I don't see your.
I'm here.
Oh, okay. So you're up, brother.
Thank you, Lynn. So I've been on drug holiday for a year and 3/4, and my PSA started to rise back in May of 24, and I've been getting Pylarify and PMSA tests every 3 months to watch it. And so I had one on Friday with Dr. Shmulewitz, and as I kind of expected, I now have a couple of lesions. And I've got one on S1, I've got one on my sacrum, and possibly one on a lymph node. But he didn't even mention anything in the lymph node. I picked that up in the Pylarify report. He gave me 3 options. 1, you can do nothing and wait 3 months. 2, you can do SBRT, which I had SBRT back in 2020 on 2 ribs. And or 3, you can do SBRT plus get back on darolutamide. Before I went on my drug holiday, I was on daro for a year and a half. So that's the update. Emotionally, I've been expecting something to pop up sometime because you can't do that forever, being a 4+3 and stage 4 metastatic. So that's kind of the update. Question is, what do I do? And I initially said, SBRT and plus daro, but I don't know if I should be doing more than that. And Rick actually spoke to Dr. E, who suggested maybe getting on Orgovix as well. So I just wanted to get the input from the group and bring everybody up to date. But I had a great year and 3/4, and I have no regrets. But now it's time to pay attention.
David, what was your PSA when it was finally picked up by the PSMA scan?
So it's interesting. PSA's been dropping. PSA this past week was 0.30, 0.32 actually, and it started in May of 24. It went up to 0.21, and then it went as high as 0.73 in September of 24, and today it's 0.30. So it has not been high.
Surprising that it dropped that much, and you were on no therapy.
Yeah,
That's a good sign.
Yeah. So, so the question is, what do I do next? And that's kind of what I'm looking for. I think I'm committed to SBRT plus daro. The question is, do I add Orgovix to that as well? Because I did great on darolutamide.
How long did she want you on the Orgovix?
I don't know, Rick. Did she say anything?
No, she didn't say, but she said, look, if you don't do well on it, you'll stop it. So but she just figures it's more important to add it right now, and hopefully she and David will talk, so they'll put the input in. I see a couple of hands up, but I really would like our friend who's upside down. I like our friend who's upside down, Steve Cavill, who's joining us from Melbourne, Australia. I asked him specifically to join us today, and I also wanted Len's input because David's history is a bit similar to both of them. Steve, do you think that that David can manage his cancer the way you've managed your cancer, with basically, and you were nova metastatic, so David started off with an RP, but do you think he can keep doing this and be successful, sort of on and off with his hormone therapy and spot radiation? What do you think?
Yeah, so like I've been doing it for 13 years. As Rick said, de novo metastatic. So in 2012, I had lesions on my spine. So I started with radiation to my prostate and then radiation to the spots and also ADT, obviously. And then literally after, I don't know, 18 months of ADT, I hated it because I was only 50 years old. So it was destroying me. So I just stopped. Well, I asked my doctor and he said, sure. And that was quite effective. My PSA stayed down and then it slowly started coming back. PSMA scan, found some new spots. I just hit them with radiation. I didn't restart ADT. and that worked the first time, knocked my PSA back down, not to zero, but to, close. And then the second lot of radiation didn't do much, so I started hormone treatment again for another 18 months or so. And then I'd kind of had enough of that, but that was around about 2017 when the Stampede results came out, so I did docetaxel. And then I stopped ADT. I started again last year, so I was 7 years off ADT. And in that time, I did stereotactic radiation twice, and the same kind of thing. The first time my PSA got to like 1, and PSMA scan found some quite clearly identifiable spots, radiated those, and that knocked the PSA back down again. So no ADT, just the stereotactic. And then the second time, so I always worked on the basis I didn't want to do the hormone treatment. So the second time, did the radiation. This was only in August last year. And it started, it didn't knock my PSA down, like it was heading up pretty rapidly. It got to like close to 1, did the radiation. It didn't knock it down again, but it also went flat, like it flatlined, like it stayed at the same number. So it was doing something, but not enough. So I restarted the ADT in November. But I only had 1 dose because of the injection, and I was taking darolutamide, and that was just flattening me. So I stopped because I was going to Europe, and I said to the doctor, listen, I'm going to Europe for 2 months or a month. I don't want to feel like this. So I'm just going to stop while I'm away. And she said, okay. And when I came back, my PSA was still 0.01, and my testosterone was 0.1. Now that's using the Australian measuring system, so I think that's equivalent to about 3 in the system you use, but in other words, tiny. So I stayed off, and that was the meeting in, I think, March, and I went back again in May, or June actually, just gone, and it was PSA still 0.01, less than 0.01. Testosterone this time was undetectable. I've never had an undetectable PSA. So I might be in the situation where my testosterone is never going to come back, so that's problematic. But I've been doing it for a long time, and I'm not going to say it's going to work for everyone, but I always took the process that I would do the stereotactic radiation by itself, and if that's the only spot, that's going to get rid of it. If it turns out it's not the only spot, you do a PSA test a month later. If it's still there or still going up, then you start the ADT. And I do ADT for like probably 18 months at a time. My doctors in Sydney were very happy with it. My doctors here in Melbourne now have moved to like less keen. So that's my experience has been some doctors say, yeah, do that. And other doctors go, well, that's not what we would recommend. But I was already like by the time I started with this new doctor, I'd been off ADT for 5 years. So what are they going to say? So anyway, it's worked for me for a very long time. I just kicked the can down the road. So,
Len, what about you? Because you're another one. You're another gent who's right in that area.
Yeah, and well, I mean, David's in better shape than I've been because between the lymph nodes and the bone lesions, I had a total of about 8 lesions, which doesn't really lend itself to MDT, metastasis-directed therapy. I mean, sure, I could have had all of them hit with radiation, but I already had massive radiation back in 2016, and I had developed radiation proctitis as a result of that. So I'm very gun shy when it comes to more radiation, and I specifically asked the doctor, the radiation oncologist, is if you treat this lymph node, which was by the left pelvic wall, am I likely to get GI side effects? And he said it's certainly possible. So I opted just to go with monotherapy with darolutamide. But your situation is different, David, and I would say you're more like Steve down in Melbourne. And I would, if I were you, I would definitely do the SBRT to that lesion. And as he said, if they knock it out and that's the only one, then you're in good shape. If PSA starts rising, then maybe you could add the ADT. That would be what I would do anyway, if I was in your shoes.
I missed,
Yep.
sorry, I did actually miss where the lesions were, David, because I will say that I'm thinking my last lot of radiation was probably my last lot of radiation because it was a couple of internal lymph nodes, inguinal, I think. Or anyway, they were right in the middle. And I honestly think they've damaged my hip joint because I never had a sore hip until like literally a week after that radiation, and it's been crook for a long time since. So at some point, and with the lymph nodes, they're little, and like I don't believe there's only one. Whereas bones are really easy, so I did forget where the lesions were.
So, David, I would ask your radiation oncologist what are the likely side effects, if any, from SBRT to that lesion in your bone.
Yep, I
And
think that's a
then
great
make the
idea.
yeah.
And we'll start there, and you know, there's nothing wrong with waiting to see what afterwards to see what my PSA does. And I
Right.
can do another Pylarify test in 3 months. I can always get on SBRT. I can always get on daro and a second line drug if I have to. But you know, it's something to think about. But I'll start there, Len. I'll start with my radiation oncologist at Northwestern, Sean Sejdev, and I'll report in.
Yeah, I think that's really important for you, David, because of the issues with your gut. So you know we got to be really sensitive about that. But the bone lesions are a rib, the sacrum, and right above the sacrum in S1 is where we know that the stuff.
David, what
So
was the SUV on the rib lesion?
SUV on the well, I don't have a rib lesion I had back in a few years back, but the SUV on the sacrum was 2.0, and the previous test was 1.8. So I'm sorry, the S1 was 3.4.
That's
And that's the
really low.
first,
That,
and
I
it's the
mean, that's
first,
close to
and it just
background SUV.
and it just showed it was not there 3 months ago. So the whole idea about doing the Pylarify test every 3 months, which Shmulewicz recommended, has been great because he's right on top of it.
Yeah.
And
And someone smarter can probably correct me on this, but I do know that PSMA, depending on which agent you use, so make sure you've got a good PSMA reader because they do give false positives on ribs. One of the particular, I don't know which one, but one of the particular traces is well known to give false positives for some.
Pylarify.
Hey?
Pylarify is the one that gives bad, but they've sort of discounted that now. To begin with, it was Pylarify that gave false positives. I think they're getting better also at reading them. Jack, what's on your mind?
Oh, no, I was going to ask about the SUV, and it's already been answered with David.
Okay. So, David, what's on your mind, Mr. M?
Nothing. David, what's on my mind is I'll go see the radiation oncologist and we'll have a discussion. And I've had great luck when he blasted with SBRT 2 ribs, and let him talk about this, and I think we might do that, and then see what happens with my PSA, and not jump on darolutamide right away and just hold off a little bit. I mean, I've been feeling great for almost 2 years.
That's a bold move. Let's see what Dr. E thinks about that one.
Well, listen, I can always jump on it. We can see what's happening. And so it's just, they're all fresh. It's not like I've been living with these for a long time. It's a big surprise. So
yeah,
it's within 3 months. So I think that's what, I don't know. My first reaction was to do darolutamide because I did pretty good on daro. I just don't know about adding Orgovix, but we'll see. I'll report back in. I'm not going to do anything without talking to everybody.
Okay, good.
Thanks, gents.
We have John Graff up next.
And can I just say a quick shout out and thank Steve for coming on and sharing with us, because we see Steve very regularly in the under 60s group, where he's still an honorary member, even though he's not under 60. And we see him in Men Speaking Freely, from Dave knows him from Men Speaking, David knows him from Men. We really appreciate you sharing and coming in this morning.
Yeah, thank you, Steve. John, go ahead.
Hi, yeah, I just had a quick question. I saw a study from ASCO 2025 saying that darolutamide is better than abiraterone in a variety of circumstances, and I was wondering if anybody had any input on it. It's been, I guess, authorized for non-metastatic, castration-free, and a bunch of other different kinds of cancer. And I don't know. I know that the idea is that you do abiraterone first, and then maybe you can switch to darolutamide later. But this study kind of saying that it's better to do the darolutamide from the get-go. I don't know if anybody saw this or has any comments or anything like that.
Yeah, the moderators have been kicking this around a little bit, and we were surprised to see that particular result.
Yeah.
Did any of you guys have a criticism of that study or anything?
Well, you know, my problem when we see these studies is that you've really got to look at them in terms of the total sequencing. So what happens when the darolutamide stops working? What will follow it? And we don't really know. So yes, darolutamide's a great drug, but the reason we think that the abiraterone is slightly better is because we know that abiraterone you can follow with a darolutamide or an enzalutamide and get something out of it. But most of these drugs, if you follow them with an abiraterone, you don't get anything out of the abiraterone. So it's not just the drug on its own, it's the whole length of time from those first two drugs that you should be looking at if you're going to make a comparison.
Right, I guess
now,
the next.
Sorry. Ben, what do you got to say on this? This is in your field.
So, I mean, the way I look at it, you get, what are we talking about? 3 extra months, you know, after switching off Abby. You know, so you've been on Abby for most of the time, and the fun drug, the daro, you get 3 months of. So that's one opinion that I have. And the other is, do we know a lot of people who've actually switched from one RC to another? Does that happen a lot in this group or in the real world?
It used to, but then they found that it wasn't very effective therapy, so they don't do it anymore. But I completely agree with Ben for the same reason that, you know, why deal with all the problems of Abby just to get yourself the chance of an additional 3 or 4 months on a second ARPI. You know, like I'd rather be on daro for years and not get any benefit after that. But personal opinion, I guess.
Yeah, Jeff Marchi, how long have you gotten out of your daro after your abiraterone?
Well, you can hear me? All right. I was on Abby for 2.5 years. I did not become resistant to it, though. I stopped taking it because it caused so many A-fib problems. And I'm now on daro for 23 months, and I've had 19 months in a row undetectable. It's really worked. But it gave me an extra 2.5 years by going on it. And if you look at the literature on it, they say go to Abby first. That's what the recommendation is, to go to Abby first. But Abby is really tough on you. I mean, it's, you know, high blood pressure, the A-fib problems, the much worse hot flashes, the brain fog, additional brain. There's a lot of issues in addition with Abby. So I mean, daro. But the problem is, you know, daro, if you become resistant to it, how long does it take you to become resistant to it? 3, 4, 5 years? Or if you get an extra 2 out of Abby, well, I've said it. that's I
I started taking it 6 years ago. I haven't taken it continuously, but I'm still sensitive to it. And the key thing in Jeff's story is he never became resistant to Abby. So we can't really say that, hey, he got a couple of years out of daro following Abby, because Abby might have worked for another few years as well.
So I guess they got to do a controlled study where they do Abby alone, Abby followed by darolutamide, and darolutamide alone, right? They got it. Then that'll take a while, right?
Forever.
Well, it's also getting the insurance company to go for darolutamide, though. I mean, it seems like the better drug, but Abby is generic, so they're easier. It's easier to get. Anyway,
Yeah.
it's an interesting thing. I guess something for the future. Yeah, Abby's tough, but it's a hard question, right? Anyway, I thank you guys for your input. It's a question.
We got a couple of people with their hands up, Len.
Yeah. Yep. Let's go with Gary and then David.
Yeah. I'm on abiraterone. I'm wondering what it is you mean by that it's tough. I have fatigue. I don't have hot flashes. And I'm, as far as short-term memory, I don't know if that's is it the abiraterone or is it me? But I'm not sure what specific problems people are referring to.
Well, Gary, you are the exception that proves the rule. I mean, no drug affects everyone exactly the same. So in your case, you didn't get any hot flashes. That's extremely unusual. But lucky you.
I've never had hot flashes.
Yeah.
Also, you have to take the prednisone with it. So you got the abiraterone and the prednisone. You got to do that dance, and it's.
I don't know what you mean by a dance. It's just 2 pills. I take them at the same time.
Well, you're supposed to do it like with one. Traditionally, you're supposed to do it without food, and then you have to wait an hour and then take the prednisone with food. And I guess there's people are taking the 1/4 with a non-fat breakfast with the prednisone.
That's what I'm doing. In other words, I take, instead of taking 4 abiraterone pills on an empty stomach, I take just 1 pill with my morning oatmeal and toss the prednisone in on top of it. And my medical oncologist, she did put me through to some papers that indicate that is, what do they say, not any worse, I think, or something.
Yeah, my pharmacist said they're not encouraging it because compliance. What is a non-fat meal, and they all the studies were based on the 1,000 milligrams of the Abby, so they're sticking with that. Or she would recommend sticking with that, but she's okay with it too. If you follow a non-fat, it's not exactly sure what a non-fat breakfast is, and I don't know. Low fat, yeah.
Yeah, in the morning I have a bowl of oatmeal with fruit and soy milk, and take my pill when I'm halfway through the oatmeal, and it just, so far it's been working for me.
Supposedly the daro doesn't cross the brain-blood barrier, so it's less brain fog. But if you're already on Lupron or whatever, you're going to have brain fog. So it's complicated. But I just appreciate everyone's input. I just thought I'd bring it up.
Okay, thank you, John. We're going to move to David Muslin. You have a hand up.
Yeah, just real quick. I was on Abby and Lupron and prednisone for 1.5 years. I stopped the Abby. I couldn't do it. I just couldn't do it anymore, and I went on monodaro for 1.5 years. And it was wonderful. So just a little context.
Thank you, David. And how about Russ, prostate cancer warrior?
Thank you. Gary, you're really lucky. I was on Zytiga, Abby, for about a year and a half, and my blood pressure shot up, and we could never dial in the prednisone dose. You dial in the prednisone dose, you take the prednisone because your cortisol gets, your ACTH axis gets messed up, and you need to replace the cortisol. But we could never dial it in just right, and my blood pressure was really high, like 200 over 150, and it's typically 115 over 65.
Okay.
It's really lucky, Gary.
Thank you, Russ. We would like to go now to Al Latimer, if he's still with us. There he is.
Yes, Mr. Latimer is still here. I don't really remember the last time I was actually on, but I guess I'll start at the beginning of my current adventure. About 2 months ago, I wasn't feeling well, and I had this backache in my lower left side. I decided to go to the emergency room, and they did some tests, and they found out I had a blocked uter. My left uter was blocked, and it was causing an infection. Excuse me. So they hospitalized me, and they put a tube in my back to drain the kidney. The urologist didn't want to do a scope at the time because I was ailing, and then I developed A-fib, which I'd never had before either while I was in the hospital. So I ended up being in the hospital for a week. They get the infection under control. The infection went away. I'm waiting for the urologist because he wants to go in and do a scope to see what's going on with the ureter. And then I get another infection before this happens. I'm back in the hospital. I left out one thing. The tube that was put into my back was put in by interventional radiology. So that worked pretty well. The kidney drained. It seemed to be working fine, but I had to deal with this infection. And then I get another infection. I'm back in the hospital again. The urologist goes in with his scope, and he finds out that he can't get from the bladder into the ureter. The opening was too small. So he aborted that. Then went back to interventional radiology, and they went through the tube that was in my kidney from the other direction and put a stent in going in the other direction. And that seemed to work pretty well. And they took out the other tube. In the meantime, I'm in the hospital for another 8 days with a second infection, which was harder to treat than the first one. Different bacteria. So then so I get out of the hospital. I'm still taking antibiotics through home care. Then eventually I have the urologist does the scope again, and he finds the whole thing was they thought that there was a tumor in my ureter that was causing the blockage, but when he went in there, it was not a tumor, it was constricted. So he put another stent in. I still have that stent in, but I dodged a big bullet because everybody was thinking that I had a tumor or I had perhaps another cancer. So that didn't happen, so I dodged a bullet. In the meantime, I have not had any cancer treatments in 2 months. I don't really know where my PSA is right now. I'm going to have a PSA test tomorrow. I've talked to Dr. Scholes in California. He has recommended that I look into a clinical trial that they're doing at UCLA on actinium called alpha break. And I found out after talking to them that the study is also being done in Miami. So I don't know if I want to do this. Actinium is much stronger and much more dangerous than the Pluvicto, which I've already had. But I'm gonna at least go through the testing and see if I'm eligible. Dr. Belusic doesn't seem to have any better ideas. I've also talked to him. He doesn't seem to have any better ideas at the moment. I guess I guess my question here is anyone else in the group been in this alpha break study, or they've now, right now it's phase 3. But anyway, that's kind of where I'm at right now. I'm actually feeling much better after 2 weeks in the hospital. Takes a lot out of you, but I'm doing better. I'm feeling okay. But of course, the prostate cancer is still lurking out there, and I've got to do something about it again. So that's my story.
Rick, I don't think we have anybody on actinium in the recent past, right?
No, and Al and I have exchanged, and we do know the principal investigator in Miami. I've actually met him. He's a good guy. So,
well, Dr. Schultz says he has several patients that are in this trial, and he's been very encouraged by the results. So that's about the best I have to go on at the moment.
I think Jim Barnes might have been on it, but I don't think you necessarily have to feel that actinium is, I forgot the word you used, but I don't think it's really much more dangerous.
Well, in that the side effects, which I had plenty of them with Pluvicto, the side effects with dry mouth and loss of sense of taste, it's significant, and I've heard it can be much worse with the actinium. Although the doctor in Miami says that they don't, the way they're doing it now, they don't seem to have a huge problem with it of the patients that he's seen so far. So anyway, that's kind of where I stand. And like I said, I don't know where my PSA is right now. I mean, it's been 2 months since I've had a treatment, so I'm sure it's quite a bit higher.
Is that study using actinium against PSMA or some other target?
Yes, it's targeting PSMA just like Pluvicto.
Oh, okay. Yeah, so you get to expect the dry mouth again. I see.
Yeah.
I would be hesitant because it's using a small molecule with actinium, and I think that's a bad combination. I think you can really get reversible salivary damage with a small molecule as opposed to an antibody.
Yeah.
Well, I don't disagree with that. I guess the question is the risk worth the chance for, a significant remission? So anyway, I'm investigating it. Haven't really decided yet, and I don't really have a better alternative right now.
Well, Al, I've said it before, I'll say it again. You are indestructible. Whatever you try, I'm sure you'll get some more mileage out of it.
I feel that way more now that thing in my ureter turned out not to be another tumor.
Yeah.
That was a big relief that came back negative. So right now I only found that out about 10 days ago, so I'm kind of celebrating that still.
Mm-hmm.
All right.
Anyway,
David, you got your hand up.
Yeah, quick question for Al. So I'm so glad to see you doing well, Al, and made it through this hospital and got through these infections. What do you expect your PSA to be? I know you're going to get it checked tomorrow, but where do you expect it to be? And I guess that's the first question.
Well, it was 160 or something before, so I expect it's probably doubled by now, probably 300 or something.
Got it. And your highest PSA has been?
Highest PSA ever is 200.
Yeah, so you're at a high level. So you think you got to go back on some sort of, you're expecting to go back on a treatment?
Well, I'm going to go back on, well, I've been on Jeftana. It wasn't really lowering my PSA much, but it was keeping the PSA at bay. And I did have 2 PSMA PETs with it, and the second one was slightly better than the first, so it did have some effect on it.
Okay.
So going back on Jeftana, I guess is a alternative, but I really like to throw something different at it.
Yep, you've been good at that. Thanks, Al. Good luck. We're here for you.
So, Rick, I'm going to take you up on your offer from our
Okay, no
telephone
problem.
conversation. And I've got surgery, minor surgery, but I have to be up early in the morning. So I'm going to turn it over to you. We have Russ Hoover and Steve White are the only two left.
Okay, so we'll go to Russ Hoover and we'll go to Steve White, and then we'll check if there's anything else. Okay. Thanks, Glenn. You did a great job.
Ciao, ciao.
Good night. Sleep well. Good luck with your surgery. Okay, so Mr. Hoover, where are you?
Where am I? Doing a little better. Pardon me?
Yeah. I meant where are you on the screen? Now I can see where you are on the screen. Okay.
Okay, I have to
bring us up to date.
Okay, in February of 2024, I had a PSMA PET scan, and there was stuff not only in my prostate, but L3, T3, and in my spine. I just had one done here in May this year. They saw what they said was a shadow, but they couldn't be sure, in my prostate, and they said all the other things, L3, T3, spine, have been resolved. In other words, there's no uptake. They can't find anything going on. So I'm like, wow.
Yeah.
I'm still on Orgovix and Nubeqa. Spoke to Dr. E last week. And here's an interesting thing. You guys talk about self-advocate. My GP annual, he gives me a full blood test, full bank. And Dr. E did too. And I had 2 blood draws a week apart. My testosterone on the GP's test, same lab, was less than 10. Of course, the one that went to Dr. E was 70. So I went back to these people and I said, what is going on? Because this is the second time in 2 years where my testosterone numbers were just unbelievable. And I had the blood work redone and they were back where they should be. So there's something going on. I'll put the name out there, Quest Labs, that they're not paying attention to what they're doing. And again, I tell them, hey, this is my assets on the line. Pay attention to what you're doing. The other thing that I would like to talk about, has anybody heard or have any work with creatine or protein supplements to help rebuild muscles?
Okay, before we go there, I just want to check. So are you in treatment right now, or are you on a holiday?
I'm on treatment right now. She wants me to stay there for the next 3 months.
Okay, so and that's Orgovix and
Nubeqa.
and darolutamide, right?
Nubeqa, yeah.
Okay, and how are you feeling on that Orgovix and darolutamide?
Less brain fog, but I still have extreme hot flashes. I'm talking 15, 20 a day. I can go through 5 or 6 shirts in an afternoon. I sweat that bad. And fatigue is a real problem for me.
And you've tried the Ember Watch, haven't you?
I have tried the Ember Watch. I don't know whether that was, wishful thinking. Long term, didn't do anything. One of the things in talking to Dr. E about this was that she said vitamin D, as in David, and vitamin B, as in boy, were extremely important in keeping hot flashes down. And my numbers when I first started with Dr. E on those 2 vitamins were very low, and she was very upset about that. So I have been on vitamin D and vitamin B supplements with her since I've been there. It's kind of interesting too, and I guess I'm sort of wondering, I don't hear much talk in this group, and maybe it's just the way I'm looking at things, about blood and about vitamins, and other than the watch, Is there anything out there that anybody has tried that has worked? I know everybody's different.
Wow.
You could try estradiol instead of Orgovyx.
What is? I've never heard the name.
It's
Estrogen.
Alternate type of ADT that doesn't cause the terrible hot flashes.
I wonder why Dr. E has not brought that up.
It's very unusual, and it's not common practice, but if you've got hot flashes that are miserable enough to wreck your life, and they haven't responded to any kind of treatment, including Ember watches or anything, you could ask her about that. There's a way to do it where you don't switch all the way to estradiol, right, guys? You just add low doses of estradiol instead of switching to high doses of estradiol, and you might be able to dramatically reduce your hot flashes.
Is that anything like Veoza that came out last year?
No, Veoza is a different drug, but that's one too. I just don't know if they've studied it in men yet.
Well, that's the problem. Dr. Lee wrote me a prescription, but my pill program won't even look at me because I'm the wrong sex.
Yeah.
Right. So you never actually tried the Veoza?
I tried it because my GP, and I'm saying this quietly, used to sneak me a couple bottles every time I saw him.
Okay.
It helped knock down the severity, but not the frequency.
Okay. So
talk
to Russ. Talk to her about supplementing with a little estrogen. She's not a fan. I know she's not a fan, but tell her, could we try it? Okay. So just say, could we try supplementing with a little estrogen and see if that helps me with this?
Okay.
Now,
I'll do that.
Why don't we talk about vitamins and what have you? Because that is, it's not we endorse them if they're complementary, and if there's evidence that says they have value, it's fine. But it's very marginal for men who have advanced cancer. It's more effective for people who have less cancer. And yeah, I mean, we can talk right now about creatinine, but I don't know what it's not going to stop your hot flashes. It's not going to change what you're feeling, but
will it help with the fatigue though, is what I'm looking at.
Marginally, I would say marginally. Let me ask John or Dr. John or Ben. I mean, what would you say about supplements to help with energy?
I would say that unless Russ has a vitamin deficiency, they won't do anything.
Okay, and I do not have a vitamin deficiency as of this point. I did when I first went to Dr. E. The only other question I have is...
Hold on.
Okay.
Ben, you want to say something on that?
No, I'm going to defer to the MD.
Okay. Anybody else want to say anything on use it? Jeff Marchi.
Yeah, a couple things. Somebody on here and also on the Mayo Clinic, which I think you also posted your question on today, didn't you? Said that tofu worked for them. Taking tofu every day worked for them.
Really?
Some people, it's something you could try. Some people have said that acupuncture works. Black cohosh, I haven't heard of anybody that it works for, but it's supposed to be.
I tried that years ago.
Okay. For me, my doctor had me get Depo-Provera shots, and it's not estrogen because I can't take estrogen because of the BRCA2. But Depo-Provera really cut back on my hot flashes. And there's other hormones like it that other people here have reported using. So you should ask your doctor, you know, I've heard Depo-Provera works. What other hormones do you know of that might help me? It made a major difference. I was getting really bad hot flashes.
So the person who used tofu was Dr. Jeff Gordon, who is a political refugee from this group. So we don't see him anymore. And he seemed to think that eating loads of tofu helped him. So because there is estrogen in tofu. So, you know, so get Regina to stock up with loads of tofu, and there's lots of good ways to cook it. She can talk to our Alexa Jet about how best to prepare it, and you know, all of a sudden, it can be really good. You know, you press the water out of it, and you soak it in soy, and you grill it. It's actually quite good. Russ, you had your hand up.
Yeah, about tofu. Yeah, it's. I was going to say pretty much what you just said. It's estrogenic, as with soy. It's really mild. And tofu, good, healthy. My MO says, yeah, eat as much as you want, but it's not going to do a heck of a lot for most people. Might do a little bit for you, great. If it does, awesome. Most people, but if it works for you, works for you.
Yeah.
Creatine, I've taken creatine for 31 years. Creatine helps a little bit with the fatigue, but it's not extreme. It's not going to just take you from wanting to nap all the time to being Superman. It's not going to do that for you. Creatine, whey protein, exercise. Exercise is extremely beneficial, and there's lots of clinical trials and studies on that. It's very beneficial, and it's in the NCCN guidelines, and most governments recommend exercise for their patients.
Yeah, I agree with the exercise. I agree with the exercise.
Russ, how often are you exercising?
Every day. I'm always out. I spend 4 hours today mowing grass.
Okay, that's not exercising.
No,
You've been around us long enough.
I know.
And you know that's not what we mean by exercising. You know, we've said to you this for such a long time, and it will help you. You've really got to go out. You've got to get your heartbeat. You've got to get that heart rate up. So, you know, get on a treadmill, or get on a stationary bicycle, or whatever it is. It will make a difference. Russ just mentioned it. We've got the studies that say it, and you've got to do it. And yeah, do you want to do it? No. Do you want to feel better? Yes. So it's up to you. But, you know, mowing the lawn or scrubbing the bathtub or something, that ain't exercise. You know that. You've been around it too long.
You just haven't seen my yard.
I'm going to move on to Steve White because it's late, and otherwise everybody will go. And Steve White, please bring us. Sorry you had to wait so long, but please bring us up to date.
All right. Well, first of all, thank you all for staying on so long. I know it's been a long call, and I really appreciate more than I can tell you how much this means to get your insights. In 2016, I had my prostate removed. It was a Gleason 3+4, very clean. There was nothing on the margins. The urologist at the time said that it was exactly what you want it to be, so felt very grateful about that. In 2022, the PSA started to increase to 0.05, so we were watching it a little bit more closely. In the past couple months, it's gone up to 0.14. The testosterone is also very high. He had a PET scan that was clean. You know, it said no evidence of recurrent neoplasm, no definite estimate of metastatic disease. And so, so the idea was, that was in October, the PET scan.
What type of PET scan?
It's a PET CT skull base to mid thigh.
Yes. What was type of PET scan? Was it a PSMA scan or was it an FDG scan or what type of PET scan?
The report I'm looking at doesn't say which of those it was.
It doesn't say what tracer they used because that's really important.
Yeah, I don't.
And you know, the question is whether they ordered the right type of PET scan.
Okay.
Do you remember them saying Pleurophy? Does that ring a bell? Pleurophy. It's a very common one.
No.
No. Okay.
Yes, it is a common one, but yeah, it could have been Pylarify, it could have been Illuccix, or it could have been. It may not have even been a PSMA scan. It might have been some other type of scan. Somewhere on the report.
The PSMA sounds familiar, that term, prior to this discussion earlier tonight, but I just don't see it on the report that I have from that.
Okay. Well, it would be good to find out because when you deliver that result, it's very different. Meaning, if it was an FDG PET versus if it was a PSMA PET.
Okay. Got it. So
one way to find out if you're looking at a report, does it say SUV max on the report?
Say that again,
SUV.
please?
Does it say SUV anyplace on the report? If it says SUV, then it's probably a PSMA scan, some type, either gallium arsenide or Pleurophy, fluvastatin or whatever it is, F18.
No, I didn't see that.
You don't see it? Okay. It's probably not then.
DICOM format image data available. Yeah, nothing that indicates either of those.
Doesn't say SUV. Probably not PSMA.
I don't know if the radiopharmaceutical would help. It's piflufostat.
Ah, there you go.
Okay. Pleurophy.
It was Pylarify. It was a PSMA. It was a PSMA.
It was. Okay.
Okay. So your PSA is up to 0.14, and they gave you a PSMA scan and they didn't find anything on it. Is that right?
That's correct. And so he recommended that I see a local radiologist, which I did, and he said, well, you know, he didn't feel like he should go forward with without having a target to aim at. And so he said, let's wait till 0.2 and do a PET scan again. Again, he's just a local radiation oncologist. And then coincident with that, the urologist went back and did a decipher test on the pathology from the surgery, and it came back high at 0.66. And so the urologist is recommending that we go ahead and start radiation because that indicates that I'm a high risk. So that's kind of where I am. You know, I'd love to. He's referred me to the University of North Carolina Multidisciplinary Cancer Conference that hasn't happened yet, but I'd love, you know, any recommendations on.
So
go ahead.
Who recommended that you go see a radiation oncologist? Who did the PET scan? Who did the PSMA PET scan?
So my urologist, Dr. McCracken here in Raleigh.
Okay. And he's the one who sent you over to the radiation oncologist, correct?
Correct.
Do you recall do you recall what we suggested you do back in the day when you came in here originally?
Yes, you had talked about going to see a Dr. Dan George at Duke.
Right.
And so I asked my urologist about that, and he said, well, he's kind of the grandfather around here, and he would likely not spend, you know, there's nothing he's going to be able to do at 0.05. So he said, let's just wait, and then you can take advantage of that advice as you progress.
Okay. And where is your urologist? Is he in a local practice?
Yes, local practice. Associated Urologist of North Carolina.
Okay. Well, I'm going to go back to what I told you before.
Okay.
You shouldn't be with your urologist at this point in time. And we have urologists who say, oh, he won't see you, he won't see you. And we get people and they go and they do see him. We just had it last week. And now at 0.14, and we don't know where it is, but I'm going to give you a better suggestion this time because Dan may be busy, but I think you can get in. And if you can't, just write to me. First of all, I'd much rather see you treated at Duke than at UNC. 6 of one and half a dozen of the other in terms of distance. We're much more comfortable with the way they treat prostate cancer at Duke. There's a young, very good GU medical oncologist. I just saw her do a View Medi. I actually wrote to her and I copied Dan, and Dan said, thank you for being so supportive to our superstar. And she was the chief resident at Duke. She's, I think you'll find her really good. Her name is McManus, Jessica McManus. Okay, I'm going to put her, and Henry just put in the chat window, it sounds like me. It does sound like you, Henry. And I'm sending you to Jessica McManus as well. And that's where I would like to see you. If it were me, that's where I would be. Get out of the hands of your urologist. They're out of their depth.
And so I'll then call her. Now, one question, the local urologist, or rather radiation oncologist that he had sent me to is within Duke. He's kind of a local guy who's part of the Duke Center. That won't matter as far as going to her, correct?
Well, first of all, he's a radiation oncologist, right?
Yeah. Yes.
And what I'm sending you to is a medical oncologist. So it's different, all right? And I would start with her, and then if she thinks you need radiation, she'll refer you to to a radiation oncologist either on the campus or at a satellite location. And sometimes those satellite locations are, the quality of the docs is not as good in the satellite locations as it is at the campus. So you have to trade off the amount of the ride. Henry, how did you do when you called Dr. McManus's office? What happened? Are you there, Henry? Yes. We can't hear you. Do you have the right microphone picked out? Oh, he's off, he's on. Now your microphone's switched on, but you may have to change your microphone on your settings. Let me quickly get you the details for McManus. I was very impressed with her when I heard her, and I would also say that Dan George is very impressed with her, and I think that's important because he is really he's a very good doc. So let me just put this in, and maybe try and exchange emails with Henry. So the two of you can share notes because you're in very similar positions.
I'll put my email into the chat.
Okay. So I said Jessica. It's Hannah. Hannah McManus is her name. I'll write it in for you. Hannah McManus. And she's got a Polish middle name, which I'm not even going to try to spell and put in there. So there you go. And Henry put his email in. Oh, Henry, you sent that just to me. All right, I will send it private. I'll send Henry's email privately to Steve White. Okay, hold on. Here it comes. Here it comes. Here it comes. Steve White. Oh, okay, there you go. So the two of you can reach out to each other and share notes. Henry is just south of Charlotte.
Great.
In South Carolina, but he's very, very close to Charlotte.
All right, a fellow Carolinian. Thank you for that.
Fellow Carolinian. So talk to each other, and Steve, that's what I would do, because we don't know, and I do agree that it is a good strategy. Wait till you get up to 0.20, and let's see what happens. You could also, have you ever had a positive PSMA scan?
No. That's the only PET scan I've ever had. So
okay, so it's possible you might be amongst the 10-15% of guys who don't make PSMA. We don't know that yet, because we haven't seen anything. So that's something that you've got to discuss. But I think that if you are with somebody like Dr. McManus, they're going to be looking at all those ideas. And as far as Dr. George, I mean, we could get you into Dr. George, but I think you're going to be happy with McManus.
that sounds wonderful to me. I'm very, if he thinks she's a rising star, and if you've been impressed by her, then that all sounds good to me.
Russ, what's on your mind?
Well, I was going to say, with the absence of mets, what you could do, and if you get a medical oncologist, you can discuss with them. We track ctDNA using either Garden 360 or, in my case, Signatera and Natera has better resolution.
Well, yeah, but hold on.
You can give an indication you're having this. But I talked to your medical oncologist about it. That's what we do. My medical oncologist likes to do that. But
Russ, it's real hard. I mean, I don't know about the Garden 360. I know you know more about it. The Garden 360 ctDNA test and how good it is. Signatera, you can't get a test for prostate cancer yet. It's not approved, and they won't do it. What they told us was
it depends on the medical oncologist. My medical oncologist likes to use it. We've used it for years on me, but it depends on the MO.
Well,
I think you need to get an MO and discuss with the MO and find out what they want to do to track the possible mets.
Yeah. So when we met with them at GU ASCO, they said they would do it. If we had anybody, we could call them directly. But if your medical oncologist has the in to get them to do it, that's fine. But it's also something that they're really doing as a courtesy for prostate cancer, because they don't have any approvals for prostate cancer at this point in time.
They don't have approvals. It depends on your MO. My MO can get it. She likes to use it. It depends on the MO. So something to bring up, something to discuss. Well, how can we track mets without, if you're PSMA negative, what do you do?
Right. So we don't know that, but he's only at 0.14, so we don't really know that for sure yet, right? If he was at 1.0 and negative, I would say yes, ctDNA makes a lot of sense. ctDNA, Steve, is these tiny little fragments of DNA that are floating around in your bloodstream, and we have a way now that we can track them, and we can look and see if you've got recurrent prostate cancer, or if you're showing cancer. So it is a good system. We've talked about using it with some of the guys who have a lot more advanced, where we can't tell where it's coming from. In your situation, where it's like an early recurrence, I don't know that I would use the. If I would cash a chit to get that done right now. I'm not sure. I mean, I'm not saying it's a bad idea. I mean, it's valid. Russ is right, but I don't know that you would need to do it. But I do think it's something you could say, well, Dr. McManus, do you think we should do this or not? I would say just wait a little bit and let your PSA rise, and let's first of all establish if you make PSMA or not. Ben, what would you say?
I'm sorry, I have not been paying
attention.
Yeah.
Oh, Ben.
You're kind of the last man awake among the moderators.
The question is, what do you think of Steve White getting a ctDNA test?
And where is Steve White in his journey?
He's looking at possible recurrence after an radical prostatectomy a couple of years ago, and his PSA is at 0.14.
Oh, so he can't get a PSMA.
So he got a PSMA test, but there was nothing showed. Would you wait, or would you start pushing for ctDNA tests? What would you do?
I don't think there's going to be enough ctDNA in the blood for them to do a test.
Okay. All right, guys. On that wise note, and we've given Steve White. Not only have we given Steve White good information, we've hooked him up with Henry. You can't beat that, because Henry's one of our AnCan groupies. He shows up in all our groups. But we love him for showing up in all our groups, and he's just facing recurrence right now. So you'll talk to Henry, and hopefully you can you can get in. But I want to get you away from this urologist. I want you to be followed by a medical oncologist, or at least a really good radiation oncologist.
That's fantastic. I will call her tomorrow.
Okay, and don't be a stranger. Don't come in every once in a while and just tell us. We're happy to see you. All right, guys. Anybody? I can't believe. God bless you all. There's 22 of you, and we're at 7. We're at I don't know what time. This is a record for this. Anybody have anything else really urgent that they want me to address before we go?
Not urgent, but can you hear me now? This is Bill.
Oh, hi, Bill Lee. We can hear you. Yes.
I don't get back here enough because of my schedule, but I'll end off the session here with good news.
Yes.
I'm 5 years, no evidence of disease for colon cancer.
Good.
And then they took me off of ADT, so I've been off of it for 3 months. PSA is less than 0.008, and my testosterone's at 22.
Okay. So now, weren't you were seeing Dr. Heath? She left, right?
Correct.
Okay. So who are you seeing now?
Dr. Zhao, SHAO. I've only seen her once, and I've seen her assistant twice now.
Okay. And she wasn't one of Dr. Heath's proteges?
Yes.
Yeah, I think. Okay. Well, I'm glad you're off the ADT. So that's really good news, and that's great. And Henry, it would be much easier for me, man, if we could talk now rather than you calling me tomorrow. Are you on the okay. Henry, can we hear you? Oh, we can't hear you. All right, well, we'll have to talk. It's just easier for me to do it in group because my days are so jammed up with, doing personal navigation is very hard for me at this point. All right. All right. Well, Henry, call. I'm going to put a telephone number in the chat window for you. Okay. It's 877-582-7011. Call them up and get them to help you fix your microphone. All right. That's the go-to support. It's right there. Oh, that only went to Steve White. Steve White doesn't need it. We could see and hear him very well. Copy, paste, everyone. This is a good number for everyone to have because we can't do technical support here, but that's who you do for your technical support. So Henry, call them up and sort out that microphone so that we can hear you. Otherwise, we'll have to have you calling back in on the telephone again. Okay, and we'll talk tomorrow. All right. I'm going to say good night to everybody.
Good night. Thank you, everyone.
Good night.
Good night.
Take care. Good night. Good night.
Thanks. Good night.
Good night.